Good evening. Welcome to our next webinar. We would like to welcome Dr. de Jager tonight. Dr. de Jager, hello to you. I haven't spoken to you before today. Thank you very much for preparing this lecture for us. We are all very excited to hear what you have to say. Dr. de Jager is a general ophthalmologist. As you might have seen, she practices in Flameshaped on Beige Nadia in Northcliffe in Johannesburg, and she's also in practice with Professor Roux, and they also have a practice in Murray Street in Brooklyn and Pretoria. Dr. de Jager, I would like to ask you just briefly, tell us, do you have any special interests? I haven't written anything special down about you, but it would be nice to know if you have any special interests.
So I must say my first love is still cataract surgery. And I think today with modern times, with toric lenses, multifocal lenses and things available, it's still my first love. But I must say I've delved into the world of LASIK and corneal refractive surgery, what I find very interesting as well. And with my colleague doing a lot of retinal surgery, I must say I've tried, really try doing a lot of retinal surgery with Prof as well, and I find it extremely interesting as well. So I must say, as we learn more about ophthalmology, there's so many fields out there, and it's just so much more interesting every time you learn something new. So yeah, we'll see what the horizon brings further.
Thank you very much. Dr. de Jager was mentored by Dr. Roux from a very early age, so she's got all this knowledge on tap. And she's got the best opportunity of most, I think, doctors to learn from him, because he's also been at this for a very, very long time. But she's her own person, and we are very happy to have you tonight. Thank you, Dr. de Jager. Over to you.
Good. So let me just put my share screen on there. Okay, so tonight I want to talk about COVID-19. And I really want to say thank you for everybody that's joining us tonight. I know it's a busy time of the year, and if I think I look back at May last year, we had lots of time to do webinars and do other things that I don't think we always had time for, and it was a great time to spend more time at home and with family. But now we're back into it again, and the schedules are full and busy, and thank you for everybody that's sending patients to me and to our practice and to Flameshaped. We really appreciate it. I thought when Louise asked me to do the webinar to talk about what do I think changed my life in the last year, and I think many of your lives as well, and that is this COVID-19 virus. So just a little bit of information that I think made a change in our practice, and maybe sharing it to you. As we go along, we will be you are more than welcome to ask questions, and I think at the end of it we can do a question and answer session as well, that Louise will help us with that. So how it affects our eyes and our practices. So just a little bit, I think we all know this, but in 2019, the World Health Organization officially termed the atypical pneumonia caused by the coronavirus COVID-19. And this is caused by the SARS-CoV-2 RNA virus. On March 11, 2020, they declared this COVID-19 outbreak a pandemic, and then our lives changed forever, dramatically. Some of us have stories of hope and healing, close encounters with near death. Others have sad stories of close family or friends that died. So we know we're currently still in this pandemic, and we're reaching the third wave with all the cases going up again, and about 2,500 cases a day worldwide. We are affected all about this. Some of us are more affected by the COVID-19 virus than others, but in effect, it all affects us. So why is it important for our eye care practices? The first doctor that really made concern or voiced concern about this virus was actually an ophthalmologist, Dr. Lee Wendliam. He was summoned by the Wuhan police on the 3rd of January for making false comments on the internet about this unconfirmed SARS outbreak. So he eventually got out of jail, went back to work, and he contracted COVID-19. On the 7th of February, he died. He had 2 young children and he was only 33 years old. And then I think the world actually stood up and said, listen, what is this? Why is it causing young people to die? And I think, unfortunately, now a year later, we can see that we still don't know everything about this virus. And even more people died from it as well. So I would like Henk just to do on a poll for us to see how many of the audience were handshakers before this COVID-19 outbreak. We're talking about before March 2020. So while we wait for that poll to come out there, the second question is going to be, let me just see if I can continue. So who are still handshakers today? Okay, so I think many of us used to make contact with our patients by shaking hands. I think that's one of the first things that our parents told us when we were small. We greet people by hand, and even our Afrikaans people were told to greet by kissing and hugging people, and now it's really taboo not to touch people. So who are still handshakers today? Let's look what happens to that 70%, 76% of our poll, of our audience. So unfortunately, we've changed the way we do our work. We've changed the way of how we greet people. And in fact, that's a little bit sad, but that's the way we learn new things about what's happening in the world. So unfortunately, we are now scared to handshake other people because we're scared that we might be the one giving them a virus. Because the amount of people we see a day and the amount of handshakes that we do, we are actually putting people at risk, and that is a little bit sad. So the elbow touch and the ankle jab, well, I think for now it's still going to stay for a little bit. Let me see if I go on. So how does this disease spread? It spreads through inhalation of viral droplets after infected patients were coughing, so that's the direct method. There's also nodes of indirect through touching surfaces where the droplets actually dropped, and then touching it by touching your own mucous membranes, your eyes, your mouth, and your nose. So aerosol-related transmission through intubation, airway suctioning, and fecal emulsification has also been described. So that's smaller particles that travels a little bit further, and then you can also actually inhale it or touch it on a surface. So the one thing that came out is the survival time on surfaces. If we think about that aerosolization, it can last for up to 3 hours. On copper, less than 4 hours. Cardboard, that take-a-lot delivery that you received, can you still get COVID from touching it? Wow, the virus can survive for up to 24 hours on it. On plastic, 72 hours. And on stainless steel, that we assumed is a good clean surface, even up for 72 hours. So what must we do to prevent ourselves from getting it and giving it to other people? So we've all heard the story about hand washing. Well, there's definitely enough evidence to prove that we should keep on washing our hands more frequently. Between every patient, we should wash our hands 20 seconds with soap and water, and we should all have alcohol-based hand rubs available. So still at VisureMed, on every patient coming in, they must clean their hands, probably the same with your practices as well. The problem is just for us is the amount of alcohol that we get on our hands. We're really getting cracked and braked surfaces that also predisposes you to get infection easier. So I must say, in between patients, I wash my hands with soap and water, but coming into the practice in the morning, we use the alcohol hand wipes. We also started buying these wipes, these buckets full of alcohol wipes. So those wipes are scattered throughout the practice, and whenever somebody were touching a chair, doorknobs, if they go into the room, the chair surface, the slit lamp, the chin rest, the headrest, the places on the table they would have held onto, all of that needs to be wiped before and after every patient sat there. So it unfortunately makes us having to clean the practice all the time. And unfortunately, our surfaces are not looking that great anymore because of the alcohol cleaning. So for now, we still have to. So masks. there's a lot of controversies and things happening about masks at the moment. What should we wear? What mask is the best? I think we've all come to realize that it's not so easy to wear a mask all time. So one of the big controversies in the beginning was the N95 mask that everybody said it's the best to wear. This is the KN95. So the difference between the two is the regulatory body that regulates it. So the N95 is from an American-based health and safety company, and the KN95 is from a Chinese-based company. So basically, though, in filtering options, they're the same, but it gets to how does it fit onto your face, and is it actually working as a filtration system as well? In the beginning, we struggled to get a 95 mask, and then we got the FFP2 mask, as you can see there on the screen. So they filter 94% of the particles greater or equal to 0.3 microns versus the 95%. So actually, it's very similar. So maybe we can ask Henk again for just how many of you are actually wearing a mask at work the whole day. So let's see what our audience answers. So the day gets quite long if you have to work through a mask the whole day, but at the end we actually got to know that we can do it. We can work with a mask. And the next question will be, if you start thinking about it, then why do we wear a mask? So great. By law, we are obliged to have a mask, and I'm glad everybody is wearing a mask at the moment. What would be the reason why you are wearing that mask? Is it to protect yourself, or is it actually to protect other people? Let's get an answer on that. So if you look at those masks, there's many masks available, and we'll look about it as well. But if it doesn't cover your nose and mouth, it's really not actually doing anything. Okay, so so it's a half-half split there. So the real answer of that is, let's go to the next slide there. So why do I wear a mask? Well, we want to not get the virus. So the SARS-CoV-2 virus, on average, is about 100 nanometers or 0.1 micrometers in size. So most of the regulated masks, the N95, the KN95, a surgical mask will filter all those particles of virus. The problem is, how does it fit onto your face? So with the problem with the surgical mask is some of the air gets inhaled outside of the filter because it's not completely onto your face. So about 30 to 35% is not filtered at all. So if it was a tight-fitting mask, filtering all the air coming in, all the air coming out, it's a completely safe mask. Cloth mask as well. It does filter particles, but does it actually filter all the particles as you breathe it in, or does some come in from underneath or not? So I want to say you wear a mask actually to protect the people around you, because the way we are wearing it, it is actually not an air filter. Some of the air is still passing out of the side. It is more a droplet stopping device, because if you speak, the droplets go out, or if you cough, that actually prevents droplet from spreading throughout the whole practice and infecting other people. So by wearing it, you're actually helping to not spread it to other people. If you wear an N95 mask correctly, tight fitting, no air coming in from the side, you're actually protecting yourself. So at the end, it depends, the answer depends on how actually are you wearing that mask. And I must say, it's not that easy doing the N95 mask all the time. So some of us do the surgical masking and try tightening a little bit on the side to make sure it's a good fit. It depends on you, but at least we make sure we're not spreading the virus all around. In our waiting room, so I know you all made plans of how things must work in your waiting room. I think the important thing is, don't let sick people come in. So screen them at the entrance. Ask about any symptoms. So we have a security guard that stands at the gates and Everybody must make sure, get answers, questions, are they have fever, are they coughing, loss of smell and taste, headache, and if they had any contact with a COVID-19 patient. And that security guard must not let them in of any of those things tested or came out positive. And that's not always so easy because people feel they have an appointment and they must come in. So the door must actually be closed. They will not be able to allow it before they go through the screening process. So magazines and toys are a no-no. We can't let people touch it all the time. Rather use a screen of photos to show, or maybe even advertisements on a screen to keep people busy while they wait. We all know about physical distancing, so 1.5 meters apart. You have to wipe the chairs after each use, so the receptionist knows that after a patient was taken through, the chair needs to be cleaned and wiped off. Better time management. We cannot overcrowd our waiting rooms. We have to make sure that there's not too many people waiting around. Unfortunately, we have a population at risk, and especially with elderly patients, we don't want them to be a risk to one another, so we mustn't let them wait too long. So handbags, the other thing about handbags are on the floor all the time, so it's really a collector of droplets. So we really tried in the beginning to people, ask them not to bring their handbags, rather bring a plastic Ziploc bag with their phone and their wallet in. It's a difficult concept because we love our handbags, but I think in a practice where we have to look at everybody and a lot of people coming in and out, that might also be helpful of making sure that we stop the spread of the virus. So breast shields, I hope all of you have made either some custom made ones. In the beginning, we made some breast shields of transparencies. We cut 2 little holes in it to make sure it fits over our slit lamp. And I think that works actually quite well. The important thing of those breast shields is to make sure that you clean them also after each patient. So the nice thing about the transparency is actually you can take it away and throw it away. We dip it in alcohol and we have a sort of a rotation system, or if you use a more perspex or hard plastic, it's actually quite easily to wipe off with alcohol as well. The other thing, which is quite difficult sometimes, is for us not to talk while at the slit lamp because we're at close proximation. So, and then keeping the mask on. So the first thing that people do is when they go to a slit lamp, they say, you're like, okay, put your chin down. They take down their mask and they put their chin on the rest. So it's becoming a habit to really say, don't take your mask off during consultation, because most people do. But by then they're already sprayed onto the breast shield, so you know you have to really clean that one as well. Make sure they keep their nose and their mouth covered with their mask, and you as well, especially when you're close contact on a phoropter or on a slit lamp. The other trick is when we put in anesthetizing drop or anesthetic drops as well for dilated examination, we know that the RNA virus is detected in tear film. So we don't want to be in contact with the tear film if we don't have to. So ask the patient to pull down their own lids and then drop it from a higher distance by your assistant or yourself, and to hold their own tissue and not you having to dab it after you put in the drop. So ask them to do their eyelid touching and things like that. Puff tonometry, there was some studies showing that puff tonometry may be a cause of spread because there is RNA virus, the SARS virus is in tear film available. So make sure, if you can, have an eye care tonometer. The nice thing about an eye care is you have a disposable probe that you put in and then you take it away and you throw it away, and then you get one for the next patient, and you can easily wipe down the instrument to make sure there's no interpatient contact. Equipment cleaning, I think in our practices it's quite troublesome because when they come in, they have something to fill in the file. So they have a pen that needs to be cleaned. Then they sit on the autorefractor. Then you take their glasses to do a lens meter, and then they sit at the phoropter. So there's actually a lot of things that needs to be cleaned. So my assistants know that everything that patient touch needs to be cleaned. So that's why the tub of alcohol wipes are next to every equipment to make sure they take a wipe and they clean it. And I think the patients appreciate it if you clean it before they use it, and then to take another one to clean it afterwards, to make sure that they know your practice is safe and you're trying everything to keep them safe as well. So if you still use Goldman contact tonometry, I must say we try avoiding it if possible, because the eye care is so much easier as well, and so much less contact and risk of transmission. The diagnostic contact lenses that we use to look through the slit lamp, that is a little bit of a problem, because that really has close contact to the patient's eye. You were touching it as well. So you have to immerse it in a diluted bleach solution or in a 3% hydrogen peroxide for at least 5 minutes. The other problem we encountered with the lenses is the fogging. So we have quite a bit of fogging issues with the mask, and I think you guys with the spectacles as well. So what we've actually done with our diagnostic contact lenses is, after use, we put it in the solution for 5 minutes and then we clean it off. And then these USB coffee mug heaters, we use that, we plug it into the USB port from the computer, and then we actually leave that lens onto that heated system. So it really helps not fogging up, so you can still do your fundoscopy through that without having to fog up the lens all the time. So fogging of rooms, we decided as a practice that we will be fogging our rooms on a daily basis. So we use viral oxy, which actually proven to kill most viruses, and the SARS-CoV virus as well. And if we have a patient, and unfortunately it still happens because people don't always tell the truth when they enter, if they were coughing, or if we were worried, or if we saw something that we think might be a high risk of a conjunctivitis or things like that, we would fog that room and keep it closed for 10 minutes, and then we'll enter it again. Cleaning of the floor, so the droplets eventually drop onto surfaces and on the floor. So we started cleaning our floors like they do in theatre with these chlorine tablets. So you can buy them at most pharmacies, and the dilution depends on how strong you want it. So we put it in the usual cleaning solution that we do for the floors, but it has a little bit of chlorine in it to make sure that we kill any residual virus droplets. The other important thing is to open the window. So if at all it's possible, we don't want an enclosed dark room with no exit of air there. So droplets will be trapped inside if there's not good airflow. So there was also some studies on central aircon and things like that, that it can spread the virus that way. At least I think we must be able to make sure there's airflow, not stagnant air. So make sure if you have a window, or there can be air flowing through the practice, a window on both sides, that there will be movement of air and the droplets not getting stuck. So in our own practice, what happened over the last year? So how many patients did we actually test positive? So which patients did we test? We still test patients for admission in hospital, because the cataracts patients are usually elderly patients. We don't want to be for 4 hours contained in a relatively small space in a pre-operative room with many other people and not know if they're COVID positive or not, because we know the problem is the asymptomatic people. They don't have any symptoms. They don't know they have it. They can still spread the disease. So you take about 5 to 8 days to develop symptoms, but you might already have contracted the disease and be spreading it. And that's where COVID-19 is so difficult to stop the spread of it, because the person who's spreading it doesn't even know they have it yet. So we have 9 patients out of about 687 patients tested so far. In our practice, 3 of our personnel were tested positive, 1 in May last year, 1 in November, and then 1 in December. And then as far as we know, there were no people contracting the virus in our practice, but that's sometimes difficult to prove where exactly did you get it. So what must you be on the lookout? So you have booked a patient for vision problem, a myop, for new glasses. What common general symptoms actually can be a sign of COVID-19? So be on the lookout if somebody complains of headaches, fever. Only in about 48% of people actually have fever. So checking temperatures is not the most accurate way of checking who must come into the practice or not. But it's an easy way of testing. I think that's why the schools and most of our practice are actually still doing the fever test. And I think, well, at least you'll find catch the very sick ones, but unfortunately you will still miss about 52% of the patient that might still have COVID-19. Smell and taste dysfunction is probably a more accurate way of testing if there's symptoms of COVID-19 or not. So that's in about 85 to 88% of people. So if anybody complains of one of those symptoms, make sure they get tested before you see them. And if you do see them, ask them to please go and get tested, and we can sort out the consultation on another day. Sore throat, also only about 53%. Coughing, quite a lot. Nausea and vomiting and diarrhea might also be a problem. So if they have any of those symptoms, rather make sure that they get tested before you see them. So I would like to tell you about a case study that we had. He was an 18-year-old male from Malawi. He visited South Africa with his parents. The history was 3 weeks ago. He had some headaches, and then after that, he started getting vision problems. So his vision at that stage, best corrected, was only 0.2, so that was quite bad. He was a myopic with astigmatism, but relatively well corrected. His pupil reactions was abnormal. The right one was larger than the left, and he had a right relative afferent pupillary defect. His anterior segment was normal, and there were no signs of conjunctivitis or neuritis. So again, what is a RAPD? Well, that means that the optic nerve is not functioning well. So if you shine a torch into the eye, a normal eye, the pupil will constrict. If you move it then to the abnormal eye, that pupil will actually dilate and not constrict because the pathway is interrupted. So there's problem with the optic nerve. So this is what his fundi looked like. That was the right one, and that is the left one. So I don't know if anybody of you ever seen this. So I must say it's quite shocking when you see this, especially in a young patient, because it absolutely looks terrible. You can't almost see where the optic nerve was there. It's just swollen so much. There's no optic disc rim visible, and then you can see something happening there at the macula as well. So what are we looking at? So if we look through the vitreous, I didn't see any vitreous cells. He had massively swollen optic disc and some surrounding hemorrhages. There's my cursor. You can see the hemorrhages there around the corner. He did have quite dilated and tortuous veins as well, but there was no retinal hemorrhages seen in the periphery. So on this image here would be like quite a large central retinal vein occlusion. But on this one here, you don't see the peripheral hemorrhages there. So that was a little bit strange. If you look then at the macula, you can see these yellow lines developing. So it's exudates in a very linear pattern going through. So this is actually what we call a partial macular star. If we then look at his OCTs, massively swollen optic nerves, causing even macular edema secondary to that as well. So that's probably what eventually made his vision deteriorate. And there you can just see those photos as well. So what is this? This looked to me like a neuroretinitis. So this means optic disc edema with a macular star. So this is sometimes, well, I've never seen one before, but this happens in children and in young adults. Most cases it's unilateral with acute loss of vision with or without ocular pain. So almost like an optic neuritis picture, but it's usually just on one side. And it's described in the literature that there's a non-specific viral illness usually preceding or accompanies the vision loss. Sometimes the vision can still be good if the optic nerve swelling is not that bad, but as it becomes worse, it actually the vision gets worse, and then they can actually develop a relative afferent papillary defect as well. Usually there are vitreous cells present, not in this case, and the disc edema develops first before the macular star. So what did we do? Well, we did some blood tests and we made sure to see that there was no compressive lesions on the optic nerve. So we were sent for an MRI. There were no signs of what we would look for an optic neuritis, no demyelination. So we did a CRP and his white cell counts were slightly elevated. He didn't have any signs of syphilis or toxoplasmosis, and his HIV was negative. But we did a SARS-CoV positive test because I actually wanted to refer him to a neurologist for IVI steroids. And then actually, well, luckily we did it because it actually became positive. So he was then referred to the neurologist for admission and treatment with the steroids to relieve the disc swelling and to prevent permanent compressive optic neuropathy and to prevent a central retinal vein occlusion. So what we learn from this is start thinking of COVID-19 in patients that present with an atypical clinical picture. A young patient with neurological sign, optic disc swelling, but with this funny retinitis macular star next to it, just doesn't really make sense. The other thing is I and all my staff, from the receptionist, because they were private patients from Malawi, so they had to get quotations for the consultation, for the MRI and all of that. All my assistants were taking them at all the machines, the fundus camera, the autorefractor, the OCT machine. So that he actually sat on all our chairs. So if we let our guard down and we take off our masks or we don't leave the surfaces, we can actually put the other people and our staff at risk. So it just teaches us again that even if we don't think of COVID-19 in a patient, but it's an atypical presentation, be on the lookout and have a high index of suspicion and rather test for COVID-19 than missing something. So luckily, well, we saw him about a month ago. None of us had COVID. So I think eventually our screening methods and our cleaning methods actually did help us not to get it, or maybe he came a little bit late in the disease process that he wasn't infective anymore. Maybe we were just lucky. So what other symptoms of COVID can we expect? I think the common thing that we heard about to look out for is a conjunctivitis. So I think the one thing in ophthalmology that I was also always scared of is the adenovirus conjunctivitis, because I really see the pain and discomfort those patients went through. So if we look at viral conjunctivitis, it's only about 0.8 to 5% of COVID positive patients actually developing a conjunctivitis. It can become hemorrhagic, so they can develop a subconjunctival hemorrhage, or it can develop pseudomembranes. Now, these pseudomembranes have to be removed, otherwise they can develop symblepharon, where the eyelid and the eye globe actually grows together. So if you have to remove those membranes, they actually advise that we use full PPE when we do it. Visor, mask, apron, gloves, all of that. So if you nowadays see a patient with conjunctivitis, especially if there's no pussy discharge, we have to think of COVID-19, and they probably have to go for a test before you see them. So conjunctival swabs were done. We know that it is present in tear film, so there's definitely a chance of spreading it. But there hasn't been a case described in literature that actually ocular fluid has infected somebody. Maybe we just didn't do the study, but there is a potential of it happening. So if it's mild and self-limiting, it probably doesn't need to be treated. Treat them with preservative-free artificial tears, cold compresses, only antibiotics if we think there's a pussy discharge secondary to the initial conjunctivitis. And if you see these patients, wear goggles, a mask, gloves when you examine them, and make sure you clean all surfaces. So if there's absence of severe pain, no light sensitivity, and the vision is still normal, you can actually treat these patients remotely. You don't have to see them because you don't want to put yourself or your personnel at risk. So if we think about COVID as well, I think we've seen in the media and we know about the risk of clotting in COVID-19. And now for the eye as well, the most common clotting problem that we see is a central retinal vein occlusion. I think most of you have seen a central retinal vein occlusion. It's those thing that if you look into the fundus, the first thing that you see is just a lot of hemorrhages covering the whole retina. Unfortunately, COVID does predispose you to that. So if you have patients that has hypertension, diabetes, or dyslipidemia, they should actually be considered putting them on an aspirin or even something more to prevent them from clotting, because clotting is one of the biggest complications of COVID, and it's terrible because it's lasting and it can really cause a lot of vision problems still further in the future. Central retinal artery occlusion are also described. So it's a sudden, severe, painless loss of vision. It's a very bad prognosis because the artery was occluded. most likely by emboli. So they have very poor vision, like counting fingers or hand movements or less. They will have a relative afferent pupillary defect. Retinal edema, so it's this very pale ischemic white retina, and characteristically would be that cherry red spot there in the middle. So unfortunately, if you see that, it's quite bad because there's not a lot that we can do because the retina is already ischemic. They need to be on something to prevent further clotting. So even if it's just to save them from having a stroke or something in the other eye, they should go on anticoagulation. So they should be seen well by a cardiologist, and nowadays even by a physician or a hematologist to look at their clotting profile and test for COVID-19 to make sure that this was not maybe the underlying cause. So previously that wasn't part of our workup. So if we saw a patient with a central retinal vein occlusion or an artery occlusion, we would work them up for normal clotting problems. Now we have to add COVID-19 to that as well. So it might have been an undiagnosed active or even a past infection of COVID-19. So that has to be tested. The not so nice thing about the COVID test, it's still quite expensive. It's 850 Rand a test. But it's one of those things that we have to do and to try to save or prevent them from having another clotting incident. Okay, one of the other interesting things that actually is quite described at the moment in young, healthy adults, it's a papillophile bitus. That was something that I thought of in that patient that we saw from Malawi as well. These horrible, horrible swollen discs. This is due to venous congestion and optic disc swelling, secondary inflammation of the retinal vein. So what causes that retinal vein inflammation? Well, we now know that COVID-19 can cause that as well. The problem is usually it has a disease cause that with the inflammation subsided, it can get quite better, quite favorably in most patients. But now with the COVID-19 patients, we see that about 30% of them can develop ischemic venous occlusion. So they develop a central retinal vein occlusion because of the occlusion and the swelling of the optic nerve fibers. And then it can even cause a neovascular glaucoma in future as well. So we have to test for COVID-19 if we see a swollen optic disc now at present, or any inflammation in the retinal vessels, they need to be checked for COVID-19 as well. We touched on optic neuritis. So optic neuritis, the biggest thing that we think optic neuritis is multiple sclerosis, doing an MRI looking for plaques in the brain as well. So now, unfortunately, COVID-19 comes in play as well. It can also cause optic neuritis, and it's even been described in people that had very mild COVID symptoms. Those patients that didn't even go to hospital, they were a bit feverish, lost their taste and smell, then actually became better, and then 2 weeks later developed the optic neuritis. They have to be treated with intravenous steroids. So we usually refer them to a neurologist to be admitted, and then on oral steroids for about 2 weeks after that as well. Okay, are you all still awake there? Okay, so another neuroophthalmic complication is Adenitis tonic pupil. So I don't know how many have seen an Adenitis tonic pupil. I don't think it's that common, but it is one of those things that can pop up now and then. Previously, we thought it was due to, well, viral illnesses, so we didn't really know. Now there's definitely been a few cases reported of an Adenitis pupil. So what is an Adenitis tonic pupil? It's a pupil that's slightly dilated and does not want to constrict with the direct light. So you would shine the flashlight into that pupil and it will not constrict. And it's the anisocoria, the difference will be even better if there's bright light shining into the eyes as well. The interesting thing about that pupil, if you ask the patient to then look at a near target, that pupil will then constrict to being the near reflex. So it won't constrict to light, but it does constrict to the near pupil. And then there's a little test that we can do to confirm it. So usually if we want to constrict the pupil, we use 1 or 2% pilocarpine. But because of the hypersensitivity of that receptor, if we dilute the 1% to a 0.1% pilocarpine, a normal pupil will not constrict on that, but an Adenitis pupil will constrict. So we still don't know how to treat it. Well, we treat it by giving the patient a 0.1% pilocarpine to keep it a little bit smaller and not that dilated, but it has been described in COVID-19. So look at pupils. If you see an addy pupil, think of COVID, make sure they go for a test as well. So Dacra Adenitis, I must say, I think I saw one patient with Dacra Adenitis, and that was about 2 months ago. And also we didn't really think of COVID as part of it. So, well, it can definitely be. So what is Dacra Adenitis? So that's usually a healthy young adult with a painful lacrimal gland swelling, causing the swelling then of the upper lateral eyelid. They have to be treated with steroids to decrease the swelling. So we don't always find a cause for it, but it has now been described in COVID-19 patients as well. So not only can COVID cause anterior segment, posterior segment, but also orbital complications. So if we look at medication, medication used to treat COVID, I think we all know about the controversy about the plasmaquine that ran out in the whole world because everybody was using it for COVID-19. Well, luckily they only used it for small periods of time. So then we don't expect to see a toxic retinal neuropathy from it. So if you were using it on a long-term basis, like a rheumatoid arthritis or SLE patient, we have to screen them for the maculopathy. But for the COVID patients, usually just use it on a short-term basis. Then all these new things that's coming about, the ivermectin, a lot of aspirin use, colchicine use, vitamin D. We don't know of all these effects yet. So we're going to have to look in the future of what might be possible causes for the eye or problems with the eye. We just know from ivermectin side, I know my colleague Prof. Roo has quite a few patients that was referred in the past for botfly problems, and then they would use ivermectin as well. So we actually always have a little bit of ivermectin available because most of the ophthalmologists refer them to Prof when they expect a patient with that. So at least we know what was ivermectin before it came out as a treatment now for COVID-19. So I think I've tried to show you what COVID-19 can cause in the eye. Be on the lookout for unusual presentation of a disease in any age group or in any phenotype. So if it doesn't really fit the picture and you're not exactly sure what's happening, well, Google, look around, ask somebody, and be on the lookout for COVID-19. The problem that we have at the moment is there's a lot of things being reported in the world now. So is it due to COVID? Is it coincidental? So the more people report on these case reports of COVID-19 related, the more we will get to know about the disease. So probably 10 years down the line, we'll have much more details of what exactly COVID-19 can do on our eyes. But as we can see, it can affect most of our eye structure. So we have to be on the lookout. So Henk, I think let's ask a question again. Have any of you been vaccinated already? Let's see. So that's also one of the big controversies at the moment. And I think whenever we meet people and they know you're in the medical field, I would ask you, would you go for the vaccine? Which vaccine would you go to? At the end, if we look at a pandemic and we look at previous pandemics and we look at virology, what are we trying to do with the vaccine? What is the world trying to do? Is giving your body a little bit of a chance to recognize that type of virus whenever you get exposed to it. So yes, there will always be side effects from anything that we do, or also from not what we do. So we know COVID itself will or can cause clotting problems. But how many people's lives can we save by not getting COVID or not getting COVID that bad because their immune system actually recognized part of that? So the problem is there's so many variations of this virus and it keeps on replicating and making new strains, and that will be forever. And if we look at HIV and all those things, it's the same problem with all viruses. But if we can at least get something to stimulate our immune system whenever we do contract it, that we have a little bit of an inborn soldier fighting against it, I think it's worth it. So I have had my vaccine on the 22nd of March, and I'm so glad to see that half of my audience have already received theirs as well. So we have to try fight this disease, and I think by vaccination would be part of that. So I think the more people that gets vaccinated, the better we have a chance of getting through this and surviving it, and telling our kids in future what we went through with this. So what should we do to avoid COVID-19? I think we should practice physical distancing. We can't always do that in our eye practice because we have to examine eyes, but make sure if we're in the waiting room, they sit a little bit apart. Community use of well-fitting masks. The less droplets there are spread, the less virus there is spreading. Adequate ventilation, make sure the windows are open. Avoid of crowded indoor spaces and also outdoor spaces. Keep washing your hands as frequently as possible and get vaccinated. I think that is one way of us helping the world to get rid of this. So thank you for your attention. I hope that there was something that you would remember from tonight's talk. And yeah, if there's any questions, I think we have a little bit of time if it's possible, Louise.
Yes, please, people, just put your questions in the question and answer section. Let me just check. There's one chat. It's just Nicole Levy saying thank you very much for informal talk. Let's just give it a minute or two. There's a raised hand. Just check what that is. Now, somebody just said it's an awesome presentation. I nearly said awful presentation instead of awesome. A real Freudian slip.
So maybe I can answer the first one. The aerosolization means, so it depends on the size of the particle. So the droplet is the biggest one, and then as it goes further, or if something makes that droplet spread into smaller ones. So what we think happens during intubation as well, when you force something into the airway are sort of stimulated and droplets actually become smaller. The problem with smaller droplets, basically, it travels further and it can last a little bit longer. So that's what I understand under aerosolization. So if nowadays you're intubated in theatre, they have a whole sort of plastic covering over the patient's face to make sure that the nurses and supporting staff surrounding the anesthetist don't get that aerosolization. Or if you suck from an airway, if there's secretions and things as well, you could also submit it. The same with, I think, with phacoemulsification. So if we do phacoemulsification, there's actually tear film on the cornea, and with the phaco causing a little bit of a vibration, they actually think that we are creating little aerosols of that tear film that can spread a little bit as well, if that answers your question. Could a single flame-shaped hemorrhage not at the disc be COVID? Well, the difficult thing is I don't think we know all these answers yet. So we know flame-shaped hemorrhages we see with retinal, we see with hypertension, we see with diabetes. So anything that can cause a bit of inflammation of a vessel can cause a flame-shaped hemorrhage. So it might be, are we going to get them to pay 850 Rand for a COVID test to know or not? Well, we must look. So a single one, maybe we can just see what happens, but multiple ones, if it's like a central retinal vein occlusion, definitely be a cause. I would definitely still check them for hypertension and diabetes. And if there's any other symptoms of headaches or loss of taste or smell, definitely test them for COVID. If breastfeeding, do you feel I should still vaccinate? Sure. I'm not 100% sure about breastfeeding. I'm not sure even about pregnancy as well. We're going to have to ask our immunologist and virologist about that. The only thing I do know about the vaccine, if you had your flu vaccine, you should wait at least, initially they said 2 weeks, but now even wait 4 weeks. So the thing with breastfeeding, the nice thing about breastfeeding is if you have antibodies being created by the vaccine in your body, you will actually give it to your child as well. So I would still get an opinion from the vaccine center, but it might be a good idea for giving antibodies to your child as well. Lots of my patients are scared of wearing contact lenses. Are they more at risk according to you? Well, we know how do we get it, the transmission of touching a surface and then touching your eyes or your mouth or your nose. That's how COVID spread. So I think people with contact lenses do touch their eyes more commonly than other people, but it's themselves touching their eyes. So we know as well that they have to clean their hands before and after they do that, and they should do it well with about at least 20 seconds of hand washing with a good soap. So are they more at risk? Probably they are a little bit more at risk, but it's probably a risk that they are willing to take. So I know there was a study about contact lenses. So we know that in the tear film of patients that have COVID, even if they don't have a conjunctivitis, there's still RNA virus in it. So if they touch a surface and then touch their eyes without cleaning, then they can give themselves COVID. So they have to wash their hands and don't touch their eyes in between. Sorry, I think I missed a question there.
There's one send a picture again with a macular star. I have a colleague who sent me a similar picture. I would like to send it to him.
Okay, so Louise, I think we can maybe
you can send it to me.
Okay. So if one has been vaccinated, is it still definitely? You should still get the flu vaccine. That's against influenza virus, but you should have the one and then only a month later have the other one. You can't get them at the same time. So I had my vaccine in March, and then now in May I had my flu vaccine. You should definitely still have your flu vaccine. Are air-conditioned spaces more dangerous? So a normal aircon that has a split unit, that means that unit that's on the outside and the thing that's the noisy part that's on the outside, and the unit, the silent part that's on the inside, that is fine because that's just blowing air. So blowing air is actually good because it keeps air flowing. The central aircon units is a problem. So if you have a central aircon and it actually moves air so that the whole area is actually going through the same system, that I think is a problem if there was aerosolization or droplets in the system. So I think that is still something that we need to get a good answer on, but split units are safe. So if you have a unit that is split and it's only for one room and not centraling through everything, I think it's safe. Do all swollen lateral abdominodactyl adenitis symptomatic of COVID or meibomian gland disease or blepharitis? So if it's just the lid margin, then we think of blepharitis. But with dactyloadenitis, the whole upper lid is so swollen because the lacrimal gland is actually beneath the bone. So it actually squeezes the eye a little bit downward as well. So if it's just on the lid, this is a deeper in. So if you see a deeper swelling, and if you lift the eyelid, you can sometimes see it looks like really swollen conjunctiva if the lateral horn of the lacrimal gland is pressing out. So you'll definitely, once you see it, you will know what it is. But it's not just the eyelid, it's deeper in. What's the next best thing to disprin if a patient has stomach ulcer or can't take anything with aspirin? So there's many other anti-clotting agents out there. Plavix is clopidogrel. So that is something that you need a script for. So your GP or your cardiologist or your gastrointestinal surgeon will advise you on that. But if you have a stomach ulcer, you should not be taking aspirin. So one of the other ones and the more advanced ones is the ones like Xarelto. Currently, they're using it in, I think, 10 milligram tablets. So there's even people using it in 2.5 milligrams as precaution. The problem with that, it's very expensive and the medical aids don't pay for that. So then we're talking about 1,000 Rand a month. So that is something that you would need to ask your GP about. Okay, I think we have still chance for the last question here. So my hubby developed what the ophthalmologist thought was a preseptal cellulitis on day 14 after COVID-19. This was early January. Was treated with a gram-negative antibiotics, gram-positive, as well as oral cortisone. Have you seen this in any of your patients? Do you think it was preseptal cellulitis or possible bacterial adenitis? It's difficult. So preseptal cellulitis, if you look at that picture of that boy that we showed, usually the Adenitis is with young kids, sub 20 years old. So I must say, if we go into I'm not sure how old your husband is, but if he's over 30, then we would rather think of a preseptal cellulitis. So there has been cases described of an orbital cellulitis as well in a COVID patient. So preseptal cellulitis is the less serious one where it's just the outside there. So I must say sinusitis or blocked sinuses could also have caused the preseptal cellulitis. So I would have treated him anyway with antibiotics with the cortisone. And I hope he cleared up well. So probably more cellulitis than a dacryoadenitis. That's more in younger patients. Okay. Good. Louise, I think that is it. Yeah.
I think so. You're welcome to send your questions to me on an email also. Dr. de Jager, I'll forward it to her. And yeah, be on the lookout. I should send your certificates within the next week or so. And thank you very much, Dr. de Jager, and all of you have a wonderful evening. The rest that is left.
Well, and yeah, good on everybody of you who survived COVID so far. That's great. I'm glad we had so many people attending.
Yes, and there's quite a bit of load shedding going on, so a few have already disappeared. So thank you very much again. Good night, everybody.
Thank you, Louise. Bye.
Bye-bye. If anybody is still listening, I just wanted to say thank you to our technical team, Henk and Caitlin, for helping us getting this all done.